Good afternoon and welcome to Dr. Andreas Kremer, who's joining us from a four-wheeled helicopter. So, we hope the signal will be solid. After all, there are no signal issues in the Alps, so everything will be fine and well. How are you, sir?
Thank you. Fine so far. What about you?
Yeah, I'm good. I'm good. We are just packing up all our stuff, ready for the EASL Congress. So we have a booth, such as it is, but we'll have lots and lots of information ready for you. So that'll be good.
That's wonderful. That is wonderful. Very much appreciated.
So good, right? And we have a medium packed in the suitcase as well. So we don't need to talk about that. So, right, all well and good. So, Andreas, I apologize, or more importantly, Mo apologizes. She says that's two in a row. You've been stuck with me. So she does send her apologies and she hopes to see you next time. So, right, we will get started. So, today we are here and we are here to answer your questions about PBC. We're not looking to give you specific medical advice, but what we're hoping to do is to give you general medical information which does not take the place of your consultation or your medical appointment, but hopefully what it does is help you in the conversations you can have in that appointment. With all of that said, delighted and grateful for Andreas to join us. And we are going to start with the PBC and section. So, Andreas, are you ready?
I'm perfectly ready.
Okay, let's do it. Let's do it. PBC and osteoporosis. Is there a link, and is treatment for somebody who has osteoporosis and with or due to their PBC, is their treatment any different?
Yes, very good point. Very good question. Indeed, there is link. PBC, primary biliary cholangitis, is a limited disease, and it, it is associated with a cholestatic enzyme pattern, and the cholestasis results in, let's say, a hampered um, gut-liver axis, where in particular the vitamins are less well absorbed in the gut. And vitamin D is one fat-soluble vitamin, which is therefore also less well absorbed in the small intestine. And aside the fact that in cholestatic liver diseases, the absorption of fat-soluble vitamins is reduced, the liver is capable of producing vitamin D in the human body. However, in a sick liver, this vitamin D production is less well working. And therefore, we have two factors why vitamin D levels are reduced in patients with PBC. And vitamin D is very important for bone mineralization and has many other important factors, which I don't want to go into detail now. But regarding osteoporosis, I think this is one reason why we have osteopenia, so an earlier stage of osteoporosis, or osteoporosis more commonly in PBC patients. And what we recommend to our patients is to perform a bone mineralization scan. A bone mineralization scan is like an X-ray scan where we check how much calcium is in the bones. And if that is reduced, then it depends a little bit on the extent of reduction, whether we talk about osteopenia or osteoporosis. And then this osteoporosis or osteopenia should be treated. Osteopenia is normally only treated with vitamin D and, depending a little bit on nutrition, also in combination with calcium. Osteoporosis needs more treatment. Osteoporosis needs anti-reabsorptive treatments, meaning that we inhibit the osteoclasts. These are the cells who we inhibit the cells so that the bone mineralization can improve again, and this is a common osteoporosis treatment. We use bisphosphonates, for example, as a very common treatment. The treatment of osteoporosis in PBC is not different from any other osteoporosis, so you can rely on a regular osteoporosis treatment. Importantly, the bone mineralization should be rechecked in certain intervals depending on the extent of bone mineral loss. I would say that ranges between 1 and 5 years. So to summarize a very long explanation, osteoporosis in PBC is similar to osteoporosis in other diseases. And yes, it should be treated and it should in particular be checked for in younger patients.
There you go. Andreas is losing his signal and I'm muting myself. So, but that's what happens when you have your very own James Bond answering your PBC questions this week. So the answer was yes. It is linked to PBC. The treatment is exactly the same. And there was a number of treatments that were listed. Okay, PBC and blood in the urine. Now, been to urologists, been to kidney specialists, tests are all normal. Sometimes microscopic blood, sometimes you can see the blood for days, and nobody understands it. Is it linked with PBC?
No, this is not linked to PBC. It's important that an adequate workup is performed in such cases, in particular if it's really meaning really outside the urine. It needs to be checked. I think it's important to clearly exclude infections in the urinary tract system can be associated with blood in the urine if erythrocytes are indeed the cause for the reddish color. And if the urinary tract infection is excluded, it needs a urological workup, for example, by a cystoscopy, meaning that you really look into the cyst. They are also on other imaging techniques.
Okay.
So not linked to PBC, but needs a dedicated workup. Exclude infections, exclude other benign disorders of the urinary tract system.
Okay. I got half of that, so I'm going to say perfect. Thank you, because it was at least 50% perfect. At least 50% that I know of. So, okay, that's helpful. Supplement called taurine. Is it okay to take taurine if you have PBC? Okay, did you get me there, Andreas?
Yeah, I hear you mentioned. Taurine is a supplement which is used in energy drinks, which you can find in many other nutritional supplies. Yes, indeed, it's reported to give you energy. There is no sufficient data to clearly support the use of taurine in disorders associated with fatigue. I cannot recommend that at this stage to regularly use taurine as a oral supplement. If person uses it and has the experience that it is of help, I don't it, but primarily there is not sufficient data to support taurine use in our PBC patients at stage.
Okay, so I'm just going to reiterate that. So again, just to double check, you said that if the taurine helps with energy levels and doesn't do any harm, it's okay to keep using it, but there's no data that supports its use in PBC. Did I hear you correctly?
Absolutely, absolutely. I mean, you know, I know that fatigue, energy loss is a significant problem. You can do a lot of, you know, things to improve that regarding regular movements, you know, to train the peripheral muscles and so on. And of course, if people have the experience that taurine is of help, I wouldn't forbid it. I would certainly support that, but there's not sufficient data to regularly recommend that to everybody.
Okay, perfect. Thank you. And I know this is a question that's come up, but it's a secondary question in terms of TUDCA, TUDCA.
Yeah, this is a typical question. You know, ursodeoxycholic acid is the baseline treatment of PBC, and it is conjugated once and transported to the liver with the amino acid glycine.
Okay, so I'm going to come in there. Because I remember your answer from last time. So what I'm going to say is, because of the signal that we're having with Andreas Bond, that we are going to refer you to the last Q&A that we did with Andreas, because he actually does a really nice section and he talks about UDCA being, what's the word in the blood?
Deconjugation, or what do you mean?
Conjugated and deconjugated and reconjugated.
Yeah.
And he gives a really, really nice explanation. So what I'll do is I'll refer you back to that one, because we have a really clear signal and we can hear every word that Andreas says. And it's a really long, detailed answer. And if that's your question, I think it would be worth going back to that, because it's a really nice, detailed answer. Back to our osteopenia, osteoporosis. Can you take vitamin D with your URSO? Now, I'm going to ask in general terms, if you're on URSO, can you take vitamin D? But also, can you take it at the same time as your URSO or different times of the day?
A very clear yes. You can take it together. There is no reason to separate it. I would recommend everybody to use vitamin D, because in most PBC patients, vitamin D levels are reduced, significantly reduced. And that's why I recommend to check, in particular, initially the vitamin D levels, and then check after an oral supplementation whether we achieve adequate levels. And there is the only aspect which needs to be made is it's a lipid soluble vitamin, so you need some food to have an optimal reabsorption in the gut. So if you only drink a glass of water in the morning with your URSO, then it's not the right time for vitamin D. Then you should take it when you eat something along with it.
Okay, perfect. Thank you. We've had a couple of questions about Ozempic or Wegovy. I'm assuming it's Wegovy, Wegovy.
Yes.
Okay. So the question is PBC and Ozempic or Wegovy. Are there any contraindications? Is there anything we need to know about? What can you tell us, please?
Yeah, you're well aware Ozempic and all the other GLP-1 analogs are, you know, have become very popular, also in people who have no liver disease, who have no other diseases, in particular, those who want to lose weight. Yes, there are contraindications. If you have a very advanced liver disease or liver cirrhosis, I would be very cautious. That would be definitely a contraindication if you have liver cirrhosis or even portal hypertension. Then this is something you should very carefully evaluate with your treating hepatologist. If you have early disease stage, there is no problem to take GLP-1 analogs if you have PBC. Of course, the current indication is diabetes and treatment of diabetes. So if you have diabetes and PBC, and GLP-1 analogs such as Ozempic are a good choice, because you do not only treat diabetes, you also lose weight, and losing weight means that also your liver becomes less fatty, and removal of the fat from a who suffers from another disease, in this case PBC, is definitely something very good, because the more trigger factors for disease progression, whether that is fat, whether this is alcohol, whether this is a virus, may accelerate PBC. So I would recommend, if you have fatty liver disease, to discuss a GLP-1 analog treatment with your gastroenterologist, hepatologist, or where are you currently treated for your PBC.
Okay, thank you. I got most of that, so helpful. Next question. Microbiome. What do we know about microbiome and PBC? Is it important in terms of those who respond to URSO? Is it important for those who don't necessarily respond to URSO? What do we know so far? And I know that what we know today is not what we'll know next week, but let's give it the best shot.
Yeah, it's a very good question. I have to admit that we hardly know anything about that. The microbiome is something which is very difficult to understand, because we only so far get signals of information of the genes of these bacterial species, but not the function of these bacteria which live in our gut.
Yeah.
So currently, we have clear evidence that the microbiota has influence on many diseases. I wouldn't be surprised if the microbiome would also influence PBC, and maybe contribute in part to patients who progress or who do not adequately respond to be, or on the hand, have a benefit and maybe cause a better treatment response if you have a certain bacterial variety in your gut, which may be of benefit regarding, for example, URSO treatment or other treatments. So to be honest, at this stage, the data is extremely limited. Whether we talk about the onset and pathogenesis of the underlying treatment, whether we underlying disease, whether we talk about the treatment options and response to treatment, when we talk about progression of the disease, we just don't know it, whether the microbiota has a significant influence or not. But regarding the effects, we know also in various other diseases which are far outside the blood flow, so it's neurological disorders, risk, many other disorders which are not as directly connected to the gut as the gut-liver axis. There is a clear influence. So I personally think there is certain influence. We just don't know it. And even if we would know that certain species would be of benefit, we would have difficulties to influence our microbiota.
Yeah.
To be honest, I personally think that a fiber-rich diet and a very, alterating and changing diet is of benefit. That is our microbiota loves. Less refined food and more natural stuff. That is what the microbiota does and makes it diverse. And diversity is protective. So that would be my recommendation at this stage.
Wonderful. All right, thank you. I appreciate that. Right, you're in a good bit of driveway. So let's keep going just now. So dun 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 dun. Right. Here we go. I have PBC and I'm in agony and pain in my hands, arms, really swollen and loss of grip. Doctor has offered me ibuprofen for the pain, but I was under the assumption that this is a tablet I should avoid with PBC. So can you talk a little about PBC and pain, also known as analgesia?
Yeah. What we know is that arthralgia, for example, is very common in PBC patients. So swollen joints and painful joints. That is commonly observed even without any clear rheumatological underlying disease. Now, if you want to treat pain in general, and this can also be a headache, the question always arises in a patient with a liver disease, what kind of painkillers am I allowed to use?
Yep.
And in regard to the painkillers, I always say it's amount you take, which make the painkiller a problem. So for a short period, even if it's a daily use, one protein, that is not harming your liver. That is not a problem. But if you need painkillers for many weeks on a daily basis or higher doses, then this can be a problem, and then you should look for alternatives. Ideally, you combine certain painkillers, let's say ibuprofen with metamizole, or you can also take smaller amount of paracetamol. So you switch them, and then you switch the mode of action, and also the toxicity is reduced. So this is my recommendation, but only for short-term use.
Okay, perfect. Thank you. We've got a couple of questions. So two questions that are kind of linked and also linked to earlier questions. So I'll let you do the best that you can. We have a couple of patients who are M2 positive, normal LFT, normal FibroScan, normal MRCP. You can tell us what an MRCP is, and normal ultrasound. The question one is, am I just early on in the disease? And question two is, because the doctors didn't give me urso, I've decided to start taking TUDCA. Is that safe? So that's a couple of really important questions.
Yes, very important questions. We know that PBC is associated with a typical antibody pattern, and this autoantibody pattern is defining the disease if we want to diagnose it. And among these autoantibodies are typically the antimitochondrial antibodies, and in particular the AMA-M2 subfraction. And this subfraction, AMA-M2, can be found in very early or premonitory disease stages, meaning that there is not a real liver disease yet. It's only the antibody which can and this is what we call actually AMA positivity. And AMA positivity is nothing we would yet, in particular if elastography, sonography, and liver tests are normal. Then we would only observe this AMA positivity once annually by measuring alkaline phosphatase. And as long as alkaline phosphatase, we would always add, of course, also the other transaminases. But in particular, if these are normal, we would not do anything. We would treat the patient if symptoms would be present, for example, pruritus, or if we would see signs of, increased fibrosis by elastography. That would be something where we would then consider biopsy to better, visualize what is happening in normal elastography, normal liver values, no treatment. Now, what was the second question? I forgot about this now.
So, if you haven't been formally diagnosed with PBC, is it safe to take TUDCA?
You mean taurine conjugated UDCA?
Yeah, TUDCA, yeah.
Yes. It is safe. It is safe. You can do that. It's way more expensive than the regular urso. And you have to imagine if you take TUDCA, it is deconjugated in the gut. So the bacteria hydrolyze taurine as well as glycine from the conjugated bile acids and make urso out of it. And urso is then reuptaken and then reconjugated in the liver to either glycine, more glycine than taurine, UDCA. And in that regard, it is safe, but it's not per se, has no benefit over taking real urso.
Okay, perfect. Ideal. All right, thank you very much. I was multitasking. I was copying a link from our YouTube channel into our Click meeting. So there you go, while you were answering that question. So thank you very much for that. Okay. In terms of, so we've got specifics and we've got Polexia, celecoxib, pantoprazole, and alendronate. And then on top of that, you've got urso. And somebody's asking about the best time to take those medicines through the day. Is there anything that you can suggest in terms of what may be contraindicated in terms of taking these drugs together, or in general?
Yes, very good point. Pantoprazole is a proton pump inhibitor. Proton pump inhibitors inhibit the production of acid in the stomach. And if you take that after you have had a cup of coffee or after you have eaten something, they don't work anymore because acid production, which is already performed, so all the acidity which is in the gut will not be, removed by PPI. It's only the futurous acid production which is so. PPIs you have to take at least 30 minutes, better 60 minutes before anything else you do. So in particular, any drinking, eating of the days. This must be the first drug you take. Of course, it's all important to state that PPIs are randomly used in many cases without a clear indication, and I don't like the long-term use of these drugs because they may facilitate infections, they may worsen bone mineralization, and in that regard, I think the indication for pantoprazole should be clearly checked and re-evaluated. There are not a lot of clear indications where routine use is indicated. If you take that one a while, that's okay, but the regular use is not recommended.
All right, perfect. That's helpful. Thank you so much.
And then the other drugs, I mean, urso, celecoxib, and so on, there is no clear, separation necessary. Urso is all taken in the morning and in the evening. It's separated throughout the day. You can do that. You can do that um, in the beginning, the first 3 months of a therapy, but later on, the bile acid pool has been homogenized with urso you take, and they can take all the urso pills in the morning or all in the evening. You don't have to separate them. That is the only further comment I wanted to make here.
All right, perfect. I appreciate that. Right, we've got a number of questions in and around second line therapy, particularly bezafibrates, or what's called Bezalip, and the 1 times 6, 7 times the upper limit of normal. Now, you and I have had many conversations privately, publicly, part of the summit last year, all of these kind of things. And this is why I love the job that I get to do. Because this patient said, if normal for ALP is 120, why is 1.67 times the upper limit of normal acceptable? Should we not be striving for the real normal? And why not address after 6 months or so? If ALP is still slightly normal, can we not give a second line therapy instead of waiting for a year? My work here is done. I can retire a happy man. See, this stuff's
Yes,
important.
it's very important, and it's a very, very clear and good question. And I always enjoy those critical questions from our.
Oh, we've lost Andreas. We've lost Andreas. Let's see if he comes back, because this is a really, really important question. So while Andreas is missing, I will tell you that we have these kind of conversations with clinicians all the time. In fact, one of the major takeaways from the summit this year was to address this and to make sure that we have conversations around normal being the new normal. So we'll wait for Andreas to come back into the signal area and for him to give his clinical thoughts. But actually, this is something that's really, really important to us. And there are a couple of questions coming up in terms of
Patient.
much, much higher outflows. Andreas, we lost you right at the start of your answer. So I've been using the opportunity to talk about events like the summit and at EASL, where we try to discuss the concept that normal is the new normal. So I was talking as a patient advocate, but now that we've got your signal back, we'd love to hear your thoughts as a clinician.
Yeah, sorry for that. So I would like to give a brief outline on this normal and 1.67 upper limit of normal. I fully agree. Normalization is the ideal treatment goal. So we should not accept 1.67, 2.0, or any other cutoff, in particular in younger patients, patients with advanced disease stages, and other risk factors, to make that comment very clear. So normalization is ideal. We have older data from large clinical trials where it was indicated that if your alkaline phosphatase after 1 year of ursodeoxycholic acid treatment is below 1.67 upper limit normal, that the outcome, the clinical outcome, is much better than if it was above 1.67. And this is clinical trial. Somebody decided to take a cutoff here, and many others use this cutoff in the future, and then we come up with these strange numbers. This is at first sight, not clearly understandable. Somebody just took an analysis and obviously saw this is a good cutoff for our cohort. And these data are originally from Canada, Toronto. Now, regarding the evaluation time point, I also fully agree that why should we wait for 1 year? And I fully agree. It's clear that if you have an adequate treatment response after 6 months. 6 months, your alkaline phosphatase is still very high. The probability that it will be significantly better after 12 months is low. And in those cases, we always start second-line therapy earlier. We have written that, we have published that in new literature, and we would fully agree that, yes, indeed, we would treat those patients earlier. We would not wait, and we would clearly evaluate treatment response after 6 months and add a second-line therapy. In particular, this is very important for the younger patients and those with advanced disease stages. So it's a very good point, and there is no reason to wait a year before starting obeticholic acid, bezafibrate, or other potential treatment options.
Okay, perfectly. Thank you. A couple of follow-up questions, if I may. So let's take a relatively young patient who, after taking URSO, is below 1.67 but not normalized. Would you consider a second-line therapy?
Sorry, he's below, or he's below 1.67, and what was the second aspect?
But not normalized.
Not normalized. Well, yes, if a patient is young, and we have clear data which is now published, so we have even Paris 2 criteria, let's say below 1.5 upper limit of normal, but not normalized, and the patient is below 62, there is a clear benefit for normalization. So yes, I would discuss in a younger patient initial treatment.
Perfect. Okay, thank you. We've also got somebody who's asking about Bezalip, which I'm assuming is bezafibrates. They are in the Netherlands, so we're assuming that obeticholic acid is not available. So in the Netherlands, what should they do in terms of a second-line therapy? What conversation should they have with their doctor?
I know that obeticholic acid is not reimbursed in the Netherlands, and in those countries where that is not available, you should always do two things. You should discuss either participation in a clinical trial where you may have the opportunity to get one of the more modern drugs with in development. And if that is not feasible, is not possible, then you should definitely discuss label therapies, and that would include bezafibrate and or budesonide. Budesonide is also a second-line off-label therapy in PBC, which should be considered as one option in those countries where in-label drugs are not available.
All right, perfect. That's helpful. Thank you. I have my new favorite question of the day. You're going to enjoy this one. What is URSO's primary function in the liver and in the gut?
Yeah, that's a very good point. There is has many research been done in contrast to other bile acids such as obeticholic acid and the endogenous bile acids, chenodeoxycholic acid we have in our blood. It does not bind to transcription factors in the liver. It regulates the liver function by post-transcriptional modification. So it enables a better secretory function of the hepatocyte by post-transcriptional mode of actions. And indeed, it has been clearly shown that not only the secretory function, but importantly, the bicarbonate secretion is improved by hepatocytes and cholangiocytes. And bicarbonate protects those cells from the toxic human bile acids. And so the more bicarbonate which is secreted into the lumen, the better this is for the protection of that's why it's called bicarbonate umbrella. And if we improve this bicarbonate umbrella, we have a benefit for our cells. And on top of that, it hydrophilizes our bile acid pool. So it is, making this very toxic hydrophobic bile acid pool more hydrophilic, more water soluble, less toxic. And so these are the major mode of actions, what we have currently understood of this bile acid in the human being.
This is why we love working with you, Andreas. Thank you so much. Great answer. Really, really simplified. So thank you. Right. My ultrasound showed a 9 mm lesion on the upper right lobe of my liver. Is this common? Should I be alarmed?
Sorry, I didn't really get that. What has been found on sonography?
A 9 mm lesion on the upper right lobe of my liver.
Okay, so it very much depends, on what kind of liver disease stage you are. So that means it's very important whether this is a very early disease stage or whether it's a cirrhotic liver. So then it depends on, what kind of configuration that has, the echogenicity. So is it, rich, echo rich, or it's very difficult to answer this question. Even if we would have a picture of that, a sonography picture, it's difficult to judge. I cannot really make a good statement on that. If you have an early disease stage and it's sharp, it's round, it's echo rich, it's in most times an hemangioma, a benign lesion, but this needs a careful workup by an expert hepatologist, and maybe contrast enhanced sonography. It should be carefully checked, and maybe additional imaging techniques such an MRI should be added.
All right, perfect. Thank you very much. Thank you. I am just recovering from cellulitis in one leg, and I still have residual edema. Can low albumin influence this?
Yes, absolutely. Albumin is one of these proteins we have in our bloodstream, which keeps the water inside our arteries and veins. And the less protein we have in our arteries and veins, more diffuses into the peripheral tissue, and this results in edema. And so if albumin is reduced, then this can be one cause for edema. And so an advanced disease stage of the liver can result in edema, can result in ascites. My recommendation here is to have a careful workup at a hepatologist, and a protein-rich diet is important. So if you have an advanced disease stage, if you have liver cirrhosis, you can roughly remember that 1.2 to 1.5 gram protein per kilogram body weight should be added or should be taken up with the nutrition on a daily basis. Meaning if you weigh 100 kilogram, then you need 120 to 150 gram of protein per day, ideally separated into 2 daily dosings. One dosing should be very late at night. It can be whey protein. You can buy that in these days in every supermarket, and you eat that with yogurt or any other thing. And this is very important for the liver to produce the proteins are required by your human body. Albumin is the most common protein which is produced by the liver.
Well, the good news is the dogs agree with you. So thank you very much for that input. All right, perfect. Thank you very much. Okay, next question is cholesterol. So somebody's had the conversation with a GP saying that people with PBC have a higher likelihood of high LDL cholesterol. So it might be worth talking about lipoprotein X. I'm still nervous about taking a statin. My overall number is 6.5 with no other risk factors. So again, we cannot give specific medical advice, but again, what would you do in your clinic? Any thoughts?
Yes, I fully agree. Cholesterol is typically increased in patients with primary biliary cholangitis. We often see that if you have no other risk factor, no other cardiovascular risk factor, there's no need to treat this hypercholesterolemia with a statin. And in that regard, I think the indication for a statin is not there. I wouldn't treat such a person in our clinic. I would certainly have a cardiological workup once done to ensure that there is no risk factor and that the heart function is normal. But if this is the case, we would not treat hypercholesterolemia in our tertiary center. This changes if you have arterial hypertension, diabetes, or smoking, or other factors which are associated. Familial risk is an important one which should be considered, which is often not asked, to be honest. But otherwise, we would not add a statin.
All
So
right,
dann bleibt
perfect.
man gerade stehen.
Thank you. I'm going to embarrass myself my pronunciation once again, but here we go. I am going to
Yeah.
ask about Charles-Horst muscle cramps. Are they linked to either low calcium or to PBC?
They are typically linked to alterations in your electrolytes. So magnesium is more important in my point than calcium, and it's not associated typically with PBC.
All right, perfect. Thank you. What is the safest antidepressant to take with PBC in stage 2 fibrosis?
There is no limitation to any specific antidepressant drug in an early disease stage. There is certainly data if you suffer additionally from pruritus that the selective serotonin reuptake inhibitors may also have a benefit for treating pruritus, but otherwise I do not foresee any limitations. I would discuss that with my treating physician, treating gastroenterologist, but I'd see any limitations here.
All right, perfect. Thank you very much. I've had PBC for 20 years. Recently, my ALK phos went from 325 to 650, but it's now dropped back to 487. All other liver tests remain constant. An MRI scan of the ducts shows thickening of the main ducts and 2 areas of something in the other ducts. We don't seem to know what those 2 areas are. The clinical advice currently is to watch and wait and see what happens. FibroScan was recently clear for cirrhosis. Any advice welcome in terms of where to go next, what the next round of questions that I should be asking?
Well, if you have cirrhosis, I wouldn't over-interpret bile duct alterations in an MRI or MRCP scan. We often have the problem that we see those diagnoses where people state, is there now an overlap of PSC or now there is the telephone joker belling here, ringing. There is no, I don't believe these bile duct alterations in cirrhotic patients. So if the bile duct is dilated in lumen, this is something to consider. If there are bile duct alterations within the liver, this should be interpreted with caution because the cirrhosis structure per se may just cause these biliary structural alterations. And in that regard, I would be cautious. So I would rediscuss that with an expert hepatologist. I would really have a clear look into that with an expert center who can interpret these pictures maybe in a better way. I think in a cirrhotic stage, we clearly have an indication for hepatocellular carcinoma screening every 6 months. Normally, this is sufficient by sonography. If sonography is limited to an adequate judgment of the liver, then we need an additional imaging technique such as the MRI. That would be my recommendation to this patient.
Okay. Now, I'd be curious to know your thoughts in terms of in and around Europe. But what I can tell you, and this is something that Dave Jones emphasizes regularly, that every single patient in the UK has the right to ask for a second opinion. And so if you're not entirely sure that your medical information or you're getting the answers that you need, or you still have concerns, I mean, A, come to us and talk it through with us and see if we can help you. But B, you are within your rights to ask for a second opinion, which means that you have the opportunity to go and see one of these experts that Andreas talks of, and then maybe get more defined answer to your question. So I just wanted to share that thought with you. Right, Andreas, I
fully agree.
Thank you. That's perfect. That's helpful. And now again, my pronunciation may be off here, but let's try. I have Petikai, Petechhiae. So I have Petikai or Petikai on my right arm that will not go away. I had it since September. The research I did on this is what led me to my hepatologist. So the question is Petikai common with this condition? And if so, is there any cream or medicine that helps?
So Petikai, I have to check myself. How was that spelled?
Petechhiae. So
Petechia. Oh, okay. Now I understand it. So these are, little tiny bleedings in your skin or, mucous membranes, often associated with, low platelet count. There are many causes for that. So if you have, for example, advanced disease stage with an enlarged spleen, then your platelet count may be reduced, and then petechia may occur solely due to the fact that you have not sufficient platelets. But there are many other causes for that. So it's very difficult to judge that from the absence. I mean, certainly, if the advanced liver disease is responsible for that, then the hepatology is in charge for that. If you have a low platelet count, this explains it. If you have, light pressure, light alterations, then these petechia may occur. And indeed, yeah, they are they are not harmful if they are real petechia. It's just an indication that you have a very local small bleeding into the skin, into the membranes that are petechia.
All right, perfect. That is most helpful. Okay, I'm assuming you're in Italy now because your signal seems to have improved no end. So okay. Right. I think those are the last questions. I'm just really checking everyone on Facebook has been read out and been asked. Yep. I think we're all good. So first off, I'd like to say thank you to your driver. I don't know who's driving you today, but the fact that they've
My
had to
wife.
sit there and listen to you go blah blah science for an hour is very impressive. So our gratitude goes to your wife for putting up with that. Obviously, your wife is here, so she will look after the boot and any bike rack that's on the back and keep you nice and safe. Um, Other than that, our very last question is EASL next week. What's the one thing
Yes.
you're looking forward to?
Oh, I'm looking forward to the new research results. I think it's a great opportunity to know the new development in all kind of liver diseases, and also to meet these experts, to exchange, to meet people like.
There you go, the kiss of death. I talked about Andreas' signal and then we lose the signal. Why did I do it? They call it the commentator's curse. I apologize. Oh, he's back. Okay, you're back now.
Okay, now this is almost the Italian net, which is not working anymore.
Okay. Okay, perfect. Well, listen, thank you very much for doing this while you were on the road. We appreciate it. We got most of your answers. If there are any comebacks, we'll come back to you with further information. But other than that, we look forward to seeing you next week. Safe travels, and thank you again for your time today.
Thank you so much, and see you next week. Thank
All right,
you.
you take care.
Bye-bye.
Thank you.